Bismillahirrahmanirrahim. We will start with the quote of the day and do good. Indeed, Allah loves the doers of good. I am Dr. Taimia Ayub and I will be presenting today the topic of dog bite under the kind supervision of Professor Dr. Saira Afzal, Institute of Public Health, Lahore. Learning outline. And this is the learning outline of today's lecture. We will start with the introduction, then epidemiological determinants, chain of transmission, clinical manifestation, diagnosis and management, levels of prevention, burden of disease of dog bite and rabies, and then we will continue with the recent updates, and at the end we will do MCQs. This is a learning outcome of today's lecture. So, introduction. Rabies is an acute, progressive, and almost universally fatal viral encephalitis disease. It is caused by rabies virus, genus Lassa virus, and family Rhabdoviridae. It is transmitted primarily through bites or scratches of warm-blooded animals, particularly carnivores such as dog, bats, cats, jackals, and wolves. Once clinical symptoms appear, case fatality is 100%. Nearly 100%. Entirely preventable through timely post-exposure prophylaxis. It is transmitted to man, usually by bites or licks of rabid animals. This is the epidemiological determinant, epidemiological triangle of rabies as a disease. So we have agent, with virulence, infectivity, addictive qualities of substance, etc. Anything can be agent. Then we have host, which can have genetic susceptibility, resilience, nutritional factors, etc. And then we finally have the environment, which have can have the sanitary conditions, social context, availability of healthcare, etc. So, agent factors. As I have explained previously, that the rabies virus is an RNA virus. It is neurotropic, travels via peripheral nerves to CNS. Incubation period is 1 to 3 months. Range is between days to years. On the right side, there is the diagram depicting the rabies virus, and you can see it has glycoprotein, matrix protein, nucleoprotein, phosphoprotein, and polymerase. So there are different structure which are shown. So it is a Lissa virus type A, family Rhabdoviridae. It is a bullet-shaped neurotropic RNA-containing virus with two types of antigen: a glycoprotein G protein antigen from the virus membrane and internal nucleoprotein antigen. The glycoprotein seems to be the only antigen capable of inducing the formation of virus neutralizing antibodies. So, there are two types of rabies virus: street virus and fixed virus. Street viruses are, on the right side, there is a comparison of street virus and fixed virus. So, street virus is freshly isolated, and fixed viruses are isolated after serial intracellular passage in rabbits or cell lines. Street virus produce Negri bodies, fixed viruses do not. After, street viruses affect salivary glands, whereas fixed viruses do not. Street viruses are pathogenic, and fixed viruses are not, except if not inactivated properly. Incubation period is 1 to 3 months of street viruses, and for fixed viruses, it is 4 to 6 days. And street virus produce disease, and fixed viruses are used for a vaccine. So this is an important comparison of street viruses and fixed viruses. Now we come to host factors. All ages are susceptible. Children at higher risk, more animal contact, no natural immunity, risk increased with deep bites and bites on head or neck. So, environmental and social factors: large stray dog population, poor animal vaccination coverage, limited access to post exposure prophylaxis, low awareness, and delayed health seeking behavior. These are again some potential sources of rabies. You can see there are raccoons, coyotes, foxes, unvaccinated livestock, unvaccinated pets, bats, and skunks. But I will show later on that in most of the countries and all over the world, the main sources are usually um dogs, but in some cases, foxes and bats, they are also important sources of rabies transmission at too large number of population. So this is a comparison between a safe animal and a rabid animal. So now we come to chain of transmission. The reservoir are the domestic dogs, main reservoir in Asia and Africa. In wild animal, it can be bats, foxes, raccoons, and similarly, dogs can also be caused. Mode of transmission: bite or scratch, licks on broken skin or mucosa, rarely organ transplantation or aerosol in laboratories. Portal of entry: broken skin or mucous membranes. Excuse me. Rabies not transmitted by casual contact, food or water, or intact skin. Okay, so the pathogenesis involves six steps from the entry of virus into the system to the invasion of different structures. First of all, there is penetration through skin after animal bite. Then there is replication in the muscles and connective tissue cells. Then entry into the peripheral nerves, ascent from spinal cord to brain, then encephalitis, and invasion of muscles, gland, and even skin, salivary glands. Now, there are five main stages when an individual develops rabies. First, is the incubation period of 30 to 90 days. It is variable. Then we have the prodromal phase of 2 to 10 days. Then we have acute neurological or encephalitis or paralytic phase of 2 to 10 days. And then patient can have coma and ultimately death. Incubation period, as I have mentioned, it can vary from 1 to 3 months. It is influenced by site of bite, viral load, host immunity. Prodromal phase, the patient will have fever, malaise, headache, pain, or paresthesia at bite site, which these are some of the signs and symptoms of the disease. You can see it can range from fever, nausea, vomiting, light sensitivity, muscle cramps, fear of water, aggression, loss of appetite, headache, diarrhea, runny nose. So these signs and symptoms also increase with intensity and they can change as the disease is progressing. Now we come to clinical manifestation, acute neurological phase, which is further divided into two categories: furious rabies, which is present in about 80% of the individual, in which there is hydrophobia, aerophobia, agitation, and hypersalivation. Then we have paralytic dumb rabies, in which there is ascending paralysis and it mimics Guillain-Barré syndrome. Symptoms of rabies, symptoms of paralytic rabies, and symptoms of furious rabies. In paralytic rabies, there can be dropped jaw, foaming in the mouth, excessive salivation, facial distortion, uncoordinated movement, difficulty in breathing, progressive paralysis, and seizures. In furious rabies, there can be extreme aggression, hallucination, hydrophobia, aerophobia, hypersensitivity to light or sound, inability to eat or drink, paralysis, and seizures. Now we come to clinical manifestation. There can be respiratory failure, cardiac arrest, and death occurs within days of symptom onset. So the clinical diagnosis, do not wait for lab confirmation. Investigating a rabies patient involve following test. Direct fluorescent antibody testing, which is the gold standard, tissue from at least two locations in the brain, preferably the brainstem and cerebellum, but it is not done routinely. Then we have CSF analysis, saliva, PCR, serum, and urine test. Skin biopsy can be done at the site of bite, corneal smear, MRI brain, or EEG. In postmortem cases, negri body can be seen, but it is rarely used now. Management. Once symptoms appear, no effective cure. Supportive care only is the main thing to do. Rabies is almost always fatal. Post-exposure prophylaxis, immediate wound washing with soap and water, greater than 15 minutes. Rabies immunoglobulin for category 3 exposure. Anti-rabies vaccine, cell culture vaccine. So we will explain one by one. So the management of rabies, case management of rabies include the following: wound care, immunization, dog observation, and general care. For wound care, flushing and washing the wounds, scratching scratches and adjoining areas with plenty of soap and water under a running tap for at least 15 minutes. Irrigation with virucidal agents, either alcohol, tincture, or 0.01% aqueous solution of iodine or povidone iodine. Suturing if necessary, but only after 24 to 48 hours, and applying minimum possible stitches. Antibiotics and anti-tetanus measures should be done. Dog observation, try to retain the dog for 10 days if possible. Observe its behavior and see if it's remained healthy for the observation period. If a dog is still alive even after the observation, it was not shedding rabies virus at the time the bite occurred. Immunization, combined administration of a single dose of rabies immunoglobulin, which is the passive immunity, and a course of vaccine for the active immunity should be done. Rabies vaccine. Rabies vaccine are of the following two types: cell culture vaccine and embryonic egg-based vaccine. Both the vaccine are free of any preservative with shelf life of more than 3 years, provided they are stored at 2 to 8 degrees centigrade and protected from sunlight. After preparation, the vaccine should be used within 6 to 8 hours if kept at correct temperature. Rabies immunoglobulin. There are two types of rabies immunoglobulin: human rabies immunoglobulin HRIG, which is given at 20 international unit per kilogram body weight, and then we have equine rabies immunoglobulin ERIG, which is given at 40 international per kilogram body weight. Rabies immunoglobulin for passive immunity is administered only once, preferably at or as soon as possible after the initiation of post-exposure vaccine, not indicated in pre and re-exposure cases. Immunoglobulin is injected into or around the wound site. The remaining, if any, is injected intramuscularly away from the site of vaccination. These are some of the pictures of rabies immunoglobulin and rabies. Again, it is the equine one, and the other one is on the right side is the human one. Okay, so WHO now, which schedule to follow and what are the recommendations for immunoglobulin and for vaccine? WHO recommended 1 week intradermal post-exposure prophylaxis vaccine schedule for exposed individuals who have not been previously immunized. WHO recommends a 1 week vaccine schedule on days 0, 3, and 7 with two site intradermal injection on each day. This is the picture of a intradermal injection being given, and you can see there is a formation of a bleb at the site where the injection is given. Confirmation of correct intradermal rabies vaccine administration. When the rabies vaccine is correctly injected into the upper skin area over the deltoid muscle in adult or the lateral thigh area of the infants, a distinct bleb with an orange peel appearance is visible. So this is the categorization of the rabies of the dog bite or suspected rabies animal bite. Exposure risk and indication for post-exposure prophylaxis. Depending on severity of the exposure, administration of a full PEP course is recommended as follows. First of all, we will divide the contact into categories. Category 1 is touching or feeding animals, animal licks on intact skin. There is no exposure in this. So for that, post-exposure prophylactic measures is washing of exposed skin surface. This should be done in every case, and no other necessary steps are necessary. For category 2, nibbling of uncovered skin, minor scratches or abrasions without bleeding. In this case, wound washing and immediate vaccination should be done. For category 3, single or multiple transdermal bites or scratches, contamination of mucous membrane, or broken skin with saliva from animal licks, exposures due to direct contact with bats, where exposure. Wound washing, immediate vaccination, and administration of rabies immunoglobulin or monoclonal antibodies. Category 2 and 3 exposure require human rabies vaccination should be given. Okay, so this is again in pictures, it is shown WHO recommended intradermal rabies vaccine schedule. For never vaccinated patient, rabies immunoglobulin are given in the green color, and rabies vaccine shortened two site. It at every visit they should be given at two intradermal sites, and then we have tetanus vaccine. So this is the complete package for a person getting bitten by a rabbit, suspected rabbit animal, and having no history of rabies vaccine. So for day zero, they should be given immunoglobulin and rabies vaccine at two sites and tetanus vaccine. On the day three, again they should be given rabies vaccine at two sites, and on day seven they should be given rabies vaccine at two intradermal sites. This is a previously given. If the patient are previously vaccinated patient, and if then only rabies vaccine should be given and tetanus vaccine. So rabies vaccine can be given at one intradermal site or four site intradermal, or tetanus vaccine on day zero, and on day three again at one intradermal site. So this is for the patients who have been previously vaccinated. This is again the schedule of vaccine, and this is intradermal route should be given 0.1 ml at each side on day 0, 3, and 7. Number of injection sites per clinic visit is if the patient is coming on day 0, then two sites. On day 3, again, there are two sites, and on day 7, there are two sites. And then not this is the schedule to be followed, and sites are deltoid region for above 2 years of children, or anterolateral thigh if the child is less than 2 years. Contraindication to vaccine. For pre-exposure prophylaxis, previous reaction to any component of vaccine. For post-exposure prophylaxis, no contraindication as severely fatal. Others, no contraindication. Similarly, for infancy, pregnancy, immunocompromised individual, including children with HIV, everybody should be given rabies vaccine, because the other option is unfortunately mortality. So I have explained all of the steps of prevention in some way, but I will try to make them come together and summarize them now by applying the three levels of prevention at primary prevention, secondary prevention, and tertiary prevention level. So again, the main goal of primary prevention is to prevent exposure and occurrence of rabies. For that, the most important thing to do is the mass vaccination of dogs, and it is recommended that there should be greater than or equal to 70% coverage of all the dogs in the in neighboring areas. Control of stray dog population, public awareness about avoiding animal bites, pre-exposure rabies vaccine for high-risk groups like veterinary doctors, animal handlers, and laboratory staff. Secondary prevention, the objective is to prevent disease after exposure but before symptoms onset. So what should be done is immediate and thorough wound washing with soap and water, timely administration of post-exposure prophylaxis, anti-rabies vaccine, and rabies immunoglobulin. For category 3, as I have explained previously, early risk assessment and surveillance of animal bite. For tertiary prevention, we have objective is to reduce complication and provide supportive and palliative care for symptomatic patients, management of complication, respiratory failure, agitation, psychological support for patient's family. Note, rabies is almost always fatal when symptoms appear. Curative treatment is not available. Now we come to burden of disease. So, rabies is a serious public health problem in over 150 countries and territories, mainly in Asia and Africa. It is a viral, zoonotic, neglected tropical disease that causes tens of thousands of deaths annually, with 40% being children under 5 years. Dog bites and scratches are cause 99% of the human rabies cases. Uh, so this is this, and about globally, 60,000 deaths are annually being attributed to rabies. and 95% of the deaths are in Asia and Africa. And among them, dogs causes more than 99% of human rabies cases, and children under 15 years, as explained previously, account for 40% of the deaths. So this is the world map showing where the rabies is affecting. As you can see, in most of the Asia and Africa, dogs are the main causes, which are shown in orange color. And again, the lines are also present, so the wildlife can also transmit rabies. And same is the case in South America, Asia, and Africa. And the white areas are showing rabies virus free areas, and this is present in Australia and some parts of Europe and North America, and some countries of South America are showing that only rabies is being transmitted or present in the wildlife, not in the dogs in those countries. So in Pakistan, estimated 2,000 to 5,000 deaths annually are attributed to rabies. Rabies is endemic, major burden due to high stray dog population, limited access to rabies immunoglobulin, and delayed post-exposure prophylaxis. So this is the situation of rabies in Punjab. As you can see, this is kind of heat map, which the colors, the lightest color, are showing the least affected rabies district, and the darkest red color are showing the most effective. So Lahore, as you can see here, it is of the lightest color in yellow, and the darkest color is of Bhakkar, and also Miyawali, and then in southern Punjab, Bahawalpur and Rajasthanpur are also showing dark color. So this is taken from a study which showed the rabies and the number of cases being recorded. So the World Rabies Day is celebrated on 28th September every year. So, rabies in Pakistan. Now we come to recent advances. This is a paper which was published in 22nd March 2024. And in this, they gave policies and recommendation for rabies in Pakistan. So, what they said was that rabies remain a lethal viral zoonosis, posing significant risk to global health, transmitted primarily through animal bite, as we have discussed. And then again, rabies account for over 55,000 mortality annually worldwide, with 31,000 cases reported in Asia, primarily affecting children. Although developed countries with well-established vaccination and animal control program have witnessed a decline in rabies incidence, resource-limited countries such as Pakistan continue to grapple with its menace, particularly affecting vulnerable populations with limited access to medical care and preventive measures. The 0 by 30 goal commitment, launched in 2015, aims to eliminate rabies, emphasizing improved diagnosis, mass dog vaccination, and responsible pet ownership. In this article, we provide an overview of the burden of rabies in Pakistan, its control measures, and challenges against it. Then Gavi is said to boost access to life-saving human rabies vaccine in over 50 countries with alliance with WHO and UAR. So the Gavi, the Vaccine Alliance, in collaboration with partners, is announcing support for human rabies vaccine for post-exposure prophylaxis as part of routine immunization. Eligible countries are receiving guidance on how to access these vaccines under Gavi's co-financing policy. The first round of application will be accepted by mid-July 2024. This development complements ongoing global efforts of 0 by 30 campaign led by United Against Rabies partner. And the partners can include FAO, WHO, and World Organization for Animal Health, WOAH. So this is the situation. And reservoirs and vectors, including domestic and wild animals. Rabies in dog is the source of 99% of human infections. On average, 40% of the rabies cases in humans occur in children under 15 years of age. And the overall economic cost of dog-mediated rabies is estimated to be $8.6 billion. So now we come to multiple choice questions. MCQ number one, a 29-year-old pregnant woman presents with a dog bite on her ankle. The dog was stray and its vaccination status is unknown. She is concerned about the safety of rabies vaccine during pregnancy. What should you advise? Rabies vaccine is contraindicated in pregnancy. Delay vaccination until after delivery. Start full exposure prophylaxis immediately as rabies vaccine is safe in pregnancy. Give only rabies immunoglobulin, no vaccine is needed. Or E. Observe for symptoms and treat only if she develops fever or neurological symptoms. Signs.
C.
Yes. Post exposure prophylaxis should be started immediately depending upon the category of the wound. A 40-year-old man is brought to the emergency department after being bitten by a rabid dog. The wound is large and deep, involving extensive tissue damage. Rabies immunoglobulin is unavailable in the hospital. What is the best alternative? Give only rabies vaccine and wait for immunoglobulin availability. Use a double dose of rabies vaccine instead of immunoglobulin. Start rabies vaccine immediately and arrange immunoglobulin as soon as possible. Do not give rabies vaccine until immunoglobulin is available or prescribe antibiotics and delay rabies prophylaxis.
C.
C.
Yes, rabies vaccine should be started immediately at the earliest. Provision of rabies vaccine and immunoglobulin after a dog bite represents which level of prevention? Primordial, primary, secondary, tertiary, or rehabilitation?
B. Secondary.
Yes, it is C secondary, right? So, a 50-year-old farmer presents to the hospital with a dog bite sustained 3 days ago. The wound was not washed properly at the time. He has received a tetanus vaccine in the past 5 years, but no rabies vaccine. The dog was a stray and disappeared after biting him. What is the best course of action? Clean the wound and prescribe oral antibiotics. Start the full rabies post exposure prophylaxis, including rabies immunoglobulin. Observe the wound and vaccinate only if signs of infection appears. Administer a tetanus booster only. Do nothing as rabies symptoms would have already appeared.
A.
B.
The wound cleaning should be done, but the dog bite was sustained 3 days ago. So the most important point at this action, which should be taken at this point, is to start the full rabies post-exposure prophylaxis, including rabies immunoglobulin. Option B. MCQ 5. A 10 years old boy is brought to the clinic after being bitten on the leg by a stray dog. The wound is deep with visible muscle exposure. What is the first step in management? Suturing the wound immediately, irrigation of the wound with soap and water for at least 15 minutes, administering a tetanus booster only, immediate antibiotic therapy, applying a tight bandage to stop bleeding.
B.
Yes,
B.
yes. Which intervention has the greatest long-term impact on reducing human rabies deaths? Increasing ICU beds, mass dog vaccination, improving laboratory diagnosis, antiviral drug development, or public awareness posters only.
B.
B.
Yes, mass dog vaccination should be done in this case. A 7-year-old boy is brought to emergency department after being bitten by a stray dog while playing in the street. The wound is located on his face and is actively bleeding. What is the most concerning risk in this case? Bacterial infection, tetanus, rabies transmission, allergic reaction, psychological trauma.
C.
Yes.
C.
Yes. A 30-year-old male patient presents with hydrophobia, fever, and confusion 3 months after a dog bite. He did not receive any post exposure prophylaxis. What is the most likely diagnosis? Tetanus, rabies encephalitis, meningitis, brain abscess, acute viral fever.
B.
B.
Yes. What is the rabies? Is the but
Encephalitis.
yes, rabies encephalitis. A public health official in Pakistan is assessing the burden of rabies cases in the country. What percentage of rabies cases in Pakistan are attributed to dog bites? 10 to 20%, 30 to 40%, 50 to 60%, 80 to 90%, or 90 to 100%?
B.
B.
Yes, in Pakistan, the cases are about 90%. So, for the key, the option is 80 to 90%, but I will again check to make sure that if they are more than 90%. So, for now, the answer is D. So, this is the YouTube channel where this video link will be posted. And thank you very much for listening.
Thank you so much, Dr. Tanya.
Thank you.